Good morning, everyone. Let me present my one-year progress on my PhD topic, which title is Investigating Different Etiologic Factors of Preterm Birth. I am Eszter Hoffmann, and I work as a resident doctor in the Department of Obstetrics and Gynecology in Semmelweis University. My vision is to contribute to the prevention of preterm birth, and my mission is improving a protocol for the treatment and prevention of vaginal infection during pregnancy. I have 3 ongoing projects. The first two investigates the efficacy of screening and treatment of vaginal infection during pregnancy to reduce the rate of preterm birth. And the third one is a genetic variation associated with preterm birth. Now let me talk about my first project, which title is Routine Screening of Vaginal Flora During Pregnancy Reduces the Odds of Preterm Birth. The background of this topic is that the incidence of preterm birth is between 5 and 18% worldwide, and in Hungary we spent almost 8 billion forints for the first 6 months hospital care of the neonates. On the left side you can see a figure where we can see that as the number of the weeks of gestation decreases, the risk of the complications and mortality gets higher and higher. The different etiologic factors behind preterm births are various, and the most important are infection and inflammation. And during the pregnancy care, there is no protocol for the screening of vaginal infection. And our aim is to see if the routine screening of vaginal infection could prevent preterm birth. Our clinical question was that regular screening of vaginal flora during pregnancy can decrease the rate of preterm birth and premature rupture of membranes. The population was pregnant women, intervention is screening of vaginal flora, the comparison is no screening, and the outcomes are preterm birth, low birth weight, premature rupture of membranes, and the risk factors of preterm birth. And our hypothesis was that regular screening of vaginal flora can reduce the rate of preterm birth. We did the systematic search on the 21st of October, and we found 13 eligible articles for the study. And now let me present our first result, which was preterm delivery before 37 weeks. We can see that routine screening of vaginal flora compared to no screening can reduce the odds of preterm birth significantly by 29%, which means that we can avoid 29 preterm deliveries out of 100. We did subgroup analysis by study type, and here we can see that RCTs didn't get significant results, but I think this data still suggests that screening of vaginal flora can have beneficial effects in the prevention of preterm birth. Our next result is preterm delivery before 32 weeks, and here we can see that by screening of vaginal flora compared to no screening, we can significantly reduce the odds of preterm birth by 49%, which means that we can avoid almost the half of the preterm deliveries before 32 weeks. Our next outcome is low birth weight, and here we can see that screening compared to no screening can reduce significantly the odds of preterm birth by 36%. Here we could do a subgroup analysis by study type as well, and here we got significant results for RCTs, so this data strongly suggests that screening of vaginal flora can have beneficial effects. And our most important and most relevant outcome is the birth weight under 1 kilogram, which is very important because these neonates usually born before the 28th week of the gestation, and they have the highest risk for complications and mortality. And that's why it's very important that we can see that the screening compared to no screening could reduce the odds of preterm delivery with the birth weight under 1 kilogram by 67%. And here we can see the first article, which is Farr et al. It seems to be an outlier, but here the population was a high-risk population, and I think it's very important to mention that among the high-risk population we could reach a higher reducing the odds of preterm birth. Here are all of our outcomes, and I was talking about the 4 most relevant ones. And as a summary, I would like to say the strengths and limitations of our study. First, to start with the strengths, I would like to mention the high number of the patients, the different type of screening methods that were examined, and these screening methods were easily executable. The limitations of our study were the low number of RCTs and the different type of screening methods and the different pregnancy care protocols in each country. As a conclusion, we can say that routine screening of vaginal flora can reduce the odds of preterm birth, and we found the strongest significance in studies where screening was performed by a healthcare specialist. And an implication for practice is that routine screening of vaginal flora is recommended during the pregnancy care, and it's strongly recommended in high-risk populations. And an implication for research is that further RCTs are needed for the pH screening and for gram staining as well, and the screening methods should be compared to each other. And we submitted our manuscript for the first time to JAMA Open Network in June, but 2 weeks ago we got a response that they rejected our submission because they couldn't find a reviewer for the article. So next time we are trying to submit it to the International Journal of Infectious Diseases. And now let me talk about my second project, which title is Investigating the Efficacy of Treatment of Abnormal Vaginal Flora During Pregnancy to Reduce the Rate of Preterm Birth and Premature Rupture of Membranes. The background of this topic is that the common cause of preterm birth is infection, and there is no guideline for managing vaginal infection during pregnancy. And if we talk about the treatment, we can say that there is oral or local treatment. We can choose metronidazole, clindamycin, clotrimazole, or lactic acid, or probiotics. Or we can say that we don't treat at all because the infection is asymptomatic. And our aim is to see if the treatment of abnormal vaginal flora could prevent preterm birth. Our clinical question is that can treatment of abnormal vaginal flora during pregnancy decrease the rate of preterm birth and premature rupture of membranes, and which is the best treatment? The population is pregnant women, intervention is treatment, any kind of treatment, comparison is no treatment, and the outcome is preterm birth, low birth weight, premature rupture of membranes, and risk factors of preterm birth. And our hypothesis is that treatment of abnormal vaginal flora can reduce the rate of preterm birth. And our clinical implication is to decrease the rate of preterm birth by updating protocols for the treatment of abnormal vaginal flora. And we did the systematic search on the 21st of October, and we repeated it and refreshed it during the summer. And at the end, we could find 41 eligible articles. And now we are in the phase of data extraction. And now let me talk about my third project in a nutshell. Its title is Genetic Variation Associated with Preterm Birth, and we are planning a genomic study. The etiology of preterm birth is variable, and both maternal and fetal genomes likely affect susceptibility. And different genes can be associated with preterm birth, but more examination is needed according to the literature. And that's why we are planning the examination of placentas that were collected from pregnancies with intrauterine growth retardation, preterm birth, and from a control group. And we are planning the examination of inflammation and preterm associated genes, for example, MBL2 and DFB1. And our aim is to identify fetal genetic variants that predispose infants to preterm birth. And as a summary, I would like to say that we submitted our first paper in June, and we are planning to submit the second paper in October, and we are just planning and constructing our third project. And to close my presentation, I would like to share a quote from my favorite basketball player who said, "Everything negative, pressure or challenges is all an opportunity for me to rise." Thank you for your attention.
Congrats, Eszter. My question would be that what does it mean regular screening in your first meta project? Once a month or once in every third month? What does it mean?
Thank you for your question. It's different in each study. That's why I mentioned as a limitation of the study that the pregnancy care protocol was different in each country, and of course the screening protocol was different in each country and in each study as well. So there were studies where they started the screening in the first trimester. There were studies where they started in the second trimester. There were studies where they only did it once during the pregnancy. There were studies where they did it in every 4 weeks of the pregnancy. So it was different in each study.
Could you see any difference in the results? I mean, if you checked, for example, if one nation is doing the screening in every month, and for example, in other nations who, for example, do not apply any screening method during the pregnancy?
We didn't compare this.
Okay, just if you check the literature, I mean.
There was not significant difference. We didn't compare this. We compared the study types. So we separated the study types, and of course, a cheaper and an easier executable study type was done in every 4 weeks or every week, for example, during the pregnancy, and the more expensive one was done rarely or only once during the pregnancy.
Okay, and the other question is which group or part of the population would be considered to be the high-risk population?
High-risk population was, there was a list, a checklist for them, and for example, preterm births in the history, or hypertension, preeclampsia, and...
What about the diabetes? I'm just asking.
Yeah, GDM. So, smoking and...
Smoking as well?
Yeah.
Really? Okay. Yeah.
Okay.
Thank you. I'm out of the questions.
Yep. Congratulations to your progress and congratulations to your rejection, actually, because this is the point when somebody gets adult as a researcher, you see, when he gets a kind of rejection, especially in a way as you get. I mean, there is no real, I would say that, editorial work. They just, I mean, that happens. That happens to all of us, and that will happen to everybody in this room when you get published. I mean, try to publish more than one paper. Some of them, I mean, some of you may be very lucky with the first one. Actually, this could make you lucky too, because that just make you stronger. So everybody should get stronger in any rejection. Okay, as we see here, I mean, as Professor Niradi shows. I'm just curious, I mean, well, your last project is actually, I mean, that's very important, but that is a kind of big thing.
Yeah.
I mean, so what is going to be the way of genomic analysis? So what kind of methods are you going to use, and what is the population which you include?
Thank you for your question. We don't know yet exactly. So we are just trying to find a laboratory and just figure out what to do with these samples exactly. But we would like to do it, but we don't have the exact protocol for that.